Morning. All right, Prarthana, you can go ahead. We'll start now.
Okay, ma'am, sure. Just a minute. Am I audible?
Yeah, yes, you are.
Yes.
Yes.
So, good evening, everybody. A very warm welcome to all of you for today's national class by Aora. Today's session focuses on pain physiology, an area that forms the backbone of effective perioperative and chronic pain management. I'm sure the discussions today will be engaging, insightful, and clinically enriching for all of us. Before we begin, it's my privilege to briefly introduce our esteemed moderators for today's session. Firstly, we have Dr. Rupinder Kaur ma'am, professor at Danan Medical College Hospital, Ludhiana, who brings immense experience in academics and regional anesthesia. Welcome, ma'am.
Thank you, Prarthana.
Next, we have Dr. Ramkumar sir, director and lead anesthesiologist at Fortis Hospital, People Tree, Bangalore, well known for his expertise in perioperative anesthesia practice. Welcome, sir.
Thank you.
And lastly, we have Dr. Shishir Agarwal, sir, Director of Anesthesia Services at Apollo Medic Super Speciality Hospital, Lucknow, who has been actively involved in advancing pain and regional anesthesia education. We are very honored to have such distinguished faculty moderating today's session. Welcome, ma'am and sir. With the permission of our moderators, we will now begin the academic session. I would like to invite our first presenter, Dr. Annie Priyanka from Ganga Hospital, Coimbatore, who is going to present about pain pathway and multimodal analgesia. Over to you, doctor. I think you can share your screen now. Is my
Good evening, ma'am. Good evening, sir.
Good evening.
I'll just share my screen.
Here, start with
So you are able to look specifically at the percentages. I'll show you how to do that. But if you go to your
Is it visible, ma'am? Is it visible, sir?
Yes.
I'll begin.
Yes, please.
Yes. Good evening, respected professors, and
Sangeeta, can you please going on?
thank you for giving me this opportunity to present today. I'm Dr. Annie Sharon Priyanka, currently pursuing AORA Fellowship in Ganga Hospital, Coimbatore, under the mentorship of Dr. Bala Venkat sir. I'm going to present my PPT on the topic pain pathway and multimodal analgesia today. The esteemed moderators are Dr. Ramkumar M sir, Dr. Rupinder ma'am, Dr. Shishil Agarwal sir. To start off, what is pain? The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So, pain is a complex sensation which is integrated at higher centers like that is the brain. It is a very subjective experience. No two people can experience pain the same way. The nerve pathway or the pain pathway is present and functioning at as early as 24 weeks of gestation. Broadly, pain can be classified as acute pain and chronic pain. Acute pain could be post-traumatic pain or post-operative pain, which is again divided into visceral somatic pain. Somatic pain could be superficial or deep somatic pain, and chronic pain could be malignant or non-malignant pain. The non-malignant pain is again classified into musculoskeletal pain and neuropathic pain. Pain may also be classified based on speed of transmission, that is as fast pain and slow pain. fast pain is usually transmitted by A delta fibers, and it is usually felt about 0.1 second after the stimulus. And slow pain, usually it is felt around 1 second after the stimulus, and it's usually transmitted by C fibers, which are unmyelinated fibers. Other types of pain are referred pain and breakthrough pain. Referred pain is when the pain is felt anywhere other than the site of the origin of pain. For example, the pain of MI, which is radiating to the neck, chest, and left arm. And then we have the breakthrough pain, which is a sudden and intense temporary flare-up of an already otherwise controlled pain. This could be triggered by any movement or medication wearing off. So what are the pain receptors, or otherwise called as nociceptors? So nociceptors are nothing but free nerve endings at the peripheral nerves. These sensory receptors are activated by noxious stimuli, which are to the peripheral tissues, and they are widely distributed in the skin, dental pulp, periosteum, and meninges. They could be high threshold mechanoreceptors which detect touch, or they could be polymodal receptors which detect heat and noxious stimuli. So there are various type of sensory fibers. They are either A fibers or C fibers. We are mainly concerned with A beta, A delta, and C. A beta are the larger fibers which are myelinated and transmit signals of light touch. A delta are smaller, lightly myelinated, slower conducting, and they transmit the sensation of sharp pain. C are the smallest and unmyelinated fibers which have a high threshold, and they transmit the noxious stimuli and dull pain. So there are various neurotransmitters which may be excitatory or inhibitory. The excitatory molecules usually amplify the pain signals, while the inhibitory molecules might attenuate the pain signals. Examples of excitatory molecules are substance P, glutamate, aspartate, and ATP. And inhibitory molecules may be norepinephrine, adenosine, serotonin, GABA, and glycine. So there are various chemical mediators involved in pain transmission. Out of those, excitation of nociceptors is by histamine, potassium, and ATP. Stimulation of nociceptors by bradykinin. Sensitization of nociceptors by PGE2 and I2. Activation by interacting with other chemical mediators by leukotrienes and PGI2. And discharge of pain-releasing substances by nociceptors mediated by substance P and glutamate. So I want to add a short note on IL-6. IL-6 is one of the pro-inflammatory cytokines like tumor necrosis factor, IL-1. These are major mediators of inflammation. They are pro-inflammatory cytokines. They mainly IL-6 mainly mediates peripheral and central sensitization. It also increases neuronal excitability by binding to specific ILC receptors, and it activates intracellular pathways and modulates various channels leading to pain sensitization. It also is a major driver of chronic inflammatory pain, and anti-IL-6 therapy are a novel treatment for chronic pain treatment. So the pain pathway has an ascending pathway and a descending pathway, and we have first order, second order, and third order neurons in both these pathways. With respect to the ascending pathway, the first order neurons transmit pain signal from the site of injury up to the spinal cord, mainly in the posterior nerve root ganglia. The second order neurons transmit pain from the spinal cord all the way up to the thalamus, which serves as the relay station. And those which transmit fast pain are present in the marginal nucleus, whereas those that transmit slow pain are present in the substantia gelatinosa. They ascend via the lateral spinothalamic tract. We have the third order neurons, which then relay the signals from the thalamus all the way up to the somatosensory cortex. They could be present in the thalamic nucleus, tectum, gray matter around the aqueduct of Sylvius. So this is the pain pathway which I've drawn, and this shows the transmission of pain from the site of injury all the way up to the brain. So this is the part, this is the right hand where there is a prick injury. This pain is transmitted all the way up to the somatosensory cortex. The somatosensory cortex is present in the cerebrum just posterior to the central gyrus. So now coming to the pathway, when there is a prick injury prick injury on the hand, it causes inflamed and damaged cells at the local site, which release a lot of inflammatory mediators like prostaglandins. These act on the peripheral nerve endings, that is the first order neuron, ends of the first order neuron, which then carry these chemical signals which are modified into electrical signals and then are carried by the first order neuron all the way up to the dorsal column of the spinal cord. Here they synapse with the second order neuron. After releasing the substance P, the second order neuron further crosses over and ascends via the spinothalamic tract all the way across the brainstem into and to relate and to reach the thalamus, where thalamus serves as the relay station. From the thalamus, it is projected onto the part of the brain which corresponds to the area that coincides with the right hand. So the right hand pain is projected on the left side of the brain, and the perception of pain is felt by the patient. Whenever there is an ascending pathway, there is always a descending pathway. The first order neuron in the descending pathway originates from the periaqueductal gray matter in the midbrain. Further on, it moves downwards and it synapses with the second order neuron in the nucleus raphe magnus. The second order neuron is a serotonin or adrenergic neuron, which then goes again and to the dorsal horn of the spinal cord. This area of the dorsal horn of the spinal cord is called as substantia gelatinosa, and it serves as a gate control. If you see in this enlarged image, in the substantia gelatinosa, you have the first order neuron coming, you have the descending neuron coming, and the second order neuron coming. The main function of the descending neuron is it releases noradrenaline and serotonin, which act on the first order neuron and prevent the release of substance P. Further on, they activate something called as an interneuron in this area, which then release endogenous opioids called as enkephalins. These enkephalins primarily have two functions. They prevent the first order neuron from releasing substance P, and they also prevent the depolarization of the second order neuron. So it blocks the pain signal from traveling up to the brain. So we come to the mechanism of pain. There are five main processes in the mechanism of pain. We have the nociception, the transduction, the transmission, the modulation, and the perception. So first we have the nociception by the nociceptors. Further, these harmful stimuli are converted into electrical signals by the nociceptors. These electrical signals are then transmitted via the peripheral nerves to the spinal cord and brain. The nervous system then modulates these signals. That is, the signals could be attenuated or amplified, and further on they reach the brain where there is perception of pain and the person ultimately feels pain. So what is nociception? Nociception is a normal protective response of the nociceptors to the noxious stimulus. These are the nociception is by the nociceptors, which are there at the free nerve endings of the peripheral nerves. The noxious stimulus is then propagated as a sensory stimulus. So what is the process of transduction? The conversion of the noxious stimulus into an action potential by the nociceptors. That is, chemical signals are further converted into electrical signals. This happens when noxious stimuli cause activation of various channels that are present in the receptor membrane, which may be ASIC channels or TRP channels or voltage-gated sodium channels. These ultimately cause the channel opening and influx of sodium ions, which then causes depolarization and generation of action potential. So this again shows the damaged cell releasing various chemical mediators, which then act on the receptors, which then act on various channels present in the receptor membrane. Transmission. The propagation of these action potential, which is generated by the nociceptors, they are propagated along the spinal cord all the way up to the brain. There are two types of neurons. The nociceptive specific neurons are present in lamina 1 and 2 of the spinal cord, and the second order wide dynamic range neurons are present in lamina 3 to 6 of the spinal cord. So modulation, as I've mentioned earlier, modulation could be augmentation or attenuation of the pain signals. The periaqueductal gray matter and the rostral ventromedial medulla of the midbrain play a very crucial role in this modulation process. And also the descending pathway plays a very important role. Various inhibitory molecules like serotonin, GABA, glycine also cause modulation of pain signals. Most of the pain management strategies act via these inhibitory mechanisms. So perception. Final stage of this mechanism of pain is the perception of pain, wherein all the inputs which are sent to the brain are integrated, and it creates a subjective awareness of pain perception. So this slide shows the various neurotransmitters, excitatory molecules which form the part of the ascending pathway which augment the pain signals, and we have the inhibitory molecules which form a part of the descending pathway which cause attenuation of the pain signals. So there are various pain theories which were put forward to explain the physiological mechanism of the pain transmission, and there is specificity theory which shows that pain is completely a separate modality with its own separate pathway. We have a pattern theory where it's proposed that pain receptors share pathway with other sensory modalities. Then the neuromatrix theory, which shows the role of brain in pain. And finally, the gate control theory, where the gate mechanism at the posterior gray horn of the spinal cord is crucial for blocking pain signals. So this slide explains the gate control theory. When the gate is open, pain signals are transmitted and pain is felt. When the gate is closed, pain signals are not transmitted and pain is not felt. Usually, the pain sensation is carried over by the small nerve fibers, that is the C fibers and the A delta fibers. And they keep the gate open and the pain is transmitted all the way up to the brain. But when A beta fibers, which are the larger nerve fibers, are stimulated, they block the pain transmission by the small fibers, and thus the gate is closed and the pain is blocked. This is what happens when we have pain in some portion of our body, and we rub it, we feel a little bit soothing effect. This is because tactile stimulation overrides the pain signals. Now coming to pain, post-operative pain. Post-operative pain is a type of acute pain. It could be visceral, somatic, or neurogenic. Somatic pain arising from skin and soft tissues, which is more sharp and localized. Visceral pain arising from visceral organs, which may be deep, crampy, or colicky. And neurogenic pain because of nerve injury, and it could be burning, tingling, or shooting pain. So this is the transmission process of pain from surgical procedure. So when there is surgery, there is a surgical incision made which causes tissue damage and inflammation, causing release of various chemical mediators which further act on the nociceptors, and these nociceptors convert the chemical signals into electrical signals, which then travel along the afferent nerves all the way up to the spinal cord and further ascend upwards via the spinothalamic tract all the way to the thalamus, which acts as a relay station and which then projects it onto the somatosensory cortex, and pain perception is felt. So there are two processes which can happen if there is prolonged post-operative pain. There is peripheral sensitization and central sensitization. So peripheral sensitization is when there's injured cells, there is surgical incision, there is injured cells, and aggressive manipulation at the site of injury causes tissue damage, which leads to inflammation, and a lot of chemical mediators are released. These basically behave as a sensitizing soup, and these cause a lot of change. They may cause the ion channels to be open for a longer time. More ion channels could be expressed. Then there could be repeated stimulation of the nociceptors at the site of injury, or there could be upregulation of nociceptors. There could be ectopic discharges because of increased sodium and calcium channel opening, and sometimes the catecholamines released could act on the sensitized nociceptors instead of the sympathetic receptors. So all these things cause the pain fiber threshold potential to be reduced. That is, the fibers have a less threshold potential, and they are at a continuous hyper excitable state. So the neurons are always in a hyper excitable state. Now, when post peripheral sensitization, when the neurons are hyper excitable, there is prolonged painful stimulus at the brain and spinal cord level, which causes a decrease in the threshold of glutamate receptors. It causes increased excitability because of the repeated C fiber stimulation. This is called as wind-up phenomenon. And we have decrease in GABA and glycine production. There could be disinhibition because of this. Increase in the total number of receptors. There could be a central reorganization of the receptors, and altered ion channel flow can happen. All these things lead to a process called as central sensitization, which then results in hyperalgesia, allodynia, spontaneous pain, increased spontaneous activity, and decreased threshold to stimuli. So when all these processes leads to sustained activation leading to peripheral and central sensitization, further it causes structural changes in the central nervous system, which leads to CNS neuroplasticity. So by this process, what happens is acute pain is, when left untreated, leads to prolonged subacute pain, which then, when left untreated, because of the sensitization and CNS neuroplasticity, forms chronic pain. So what are the consequences of inadequate pain management? So with respect to heart, there could be myocardial O2 consumption can increase, which may cause MI. There could be decreased GI motility. There is delayed emptying, delayed recovery. Lungs, there may be atelectasis, hypoxemia, so patient will be more susceptible to infections. There is increased catabolic demands, which leads to poor wound healing and muscle breakdown. So patient has weakness and impaired rehabilitation. And it also causes sleeplessness and helplessness. So patient has anxiety, fear, and a whole state of depression. And because of the peripheral and central sensitization, it mainly does not respond to the normal analgesic drugs that are available. So there will be untreated acute pain, which leads on to chronic pain. So what is the basic principle of treating post-operative pain? The primary objective is to prevent the occurrence of peripheral and central sensitization, so that there is no CNS neuroplasticity and chronic pain development. So this can be achieved by administering preemptive analgesia. Also, furthermore, we should prevent the process of CNS neuroplasticity, which again is by administering anti-hyperalgesic and anti-allodenic drugs. So these are the various anti-hyperalgesic and anti-allodenic drugs. It could be the NSAIDs, the COX-2 inhibitors. We have clonidine, IV and intrathecal, which can be used, gabapentinoids. And for anti-hyperalgesic, we have TCAs, tricyclic antidepressants, as well as TENS, trans cutaneous electrical nerve stimulation. For both, we can use midazolam intrathecal, and for allodenic drugs, anti-allodenic drugs, we even have low-dose propofol. So what is preemptive analgesia? Preemptive analgesia is defined as a treatment which is given prior to the surgery. That is, it is given pre-incision. By giving analgesic treatment at the pre-incision point, what happens is it prevents central sensitization and wind-up phenomenon from occurring. That is,
wanted to do by
sir?
continue.
Okay. It prevents the central sensitization and wind-up phenomenon from occurring. So what happens is there is decreased hyperalgesia, and it prevents the acute pain from becoming into chronic pain. So some of the drugs which can be used for preemptive analgesia are acetaminophen, NSAIDs, gabapentinoids, opioids, nerve blocks, and even epidural analgesia. So why do we need multimodal analgesia? From whatever we've seen that pain is multifaceted and it's from multiple sources. No single analgesic can cover all type of pain. And when we use MMA, it leads to increased efficacy, reduced dosages, and minimal adverse effects. And overall, it could create an improved outcome. So what is multimodal analgesia? The ASA defines multimodal analgesia as a multidisciplinary approach to pain management with the goal to maximize the analgesic effects and minimize the side effects of the medications. So it is usually achieved by combining different doses of drugs. These drugs can act by different mechanisms at different sites of the nervous system. We aim at an additive or synergistic analgesia with reduced adverse effects, but we should keep in mind that what procedure the patient is undergoing, also the side effects that the individual may experience, and the various comorbidities that the individual may have. So what are the various drugs used in multimodal analgesia? Whatever may be the drugs that we use, our effect could be synergistic, additive, or subadditive. So the principal drugs or the analgesics which are used could be opioid analgesics, systemic non-opioid analgesics, and now we even use regional anesthesia as a principal mode of MMA. And then we have adjuvants, or also called as co-analgesics, like gabapentinoids, NMDA receptor antagonists, alpha-2 adrenergic agents, glucocorticoids, and other drugs such as antidepressants and lidocaine. So all these drugs, they act as at various sites. So for example, we at the transduction site, we have the local anesthetics and NSAIDs which act, which then we have a local anesthetic acting on the transmission pathway. Then at the transduction, they reduce the inflammatory mediators and decrease nociceptor activation. When the and LA in the transmission process, they block the sodium channels and block the pain conduction overall. And the local anesthetics, opioids, and alpha-2 agonists can enhance inhibitory pathways and thus decrease neurotransmitter release and attenuate the pain signals. And further, we have centrally acting drugs like opioids, acetaminophen, alpha-2 agonists, tricyclic antidepressants, ketamine, and pregabalin, which further modify the way how brain can perceive pain. So this is the PATHOPHYSIC ladder, which was introduced in 1986. In this, it formulates a stepwise manner approach to pain management. So for mild pain, we use non-opioids. For mild to moderate pain, we could use weak opioids along with non-opioids. Weak opioids could be hydrocodone, codeine, and tramadol. For moderate to severe pain, we use strong opioids like morphine or fentanyl. And the fourth new step is the employment of interventional treatments in the WHO analgesic ladder. It's mainly for patients who do not respond to conventional pain treatments or they suffer from some undesirable side effects. So some of the interventional treatments are spinal cord stimulation, nerve blocks, epidural analgesia. Furthermore, we can add adjuvants like tricyclic antidepressants or topical therapies or steroids anyway in any step of the WHO ladder. So the first drugs that we'll see are the non-steroidal anti-inflammatory drugs. They prevent
Dr. Annie, am I audible?
Yes.
Sorry to interrupt. You have
Yes.
15 minutes
Yes.
of time and it's almost more than double the time. So how many more slides?
I'll just run through these slides, ma'am. Probably
Yeah, because two others are waiting, ma'am. Sorry.
10 minutes, ma'am.
Okay.
So these are the non-steroidal anti-inflammatory drugs and they prevent prostaglandin synthesis. Out of these, we have the COX-1 inhibitors and COX-2 inhibitors. COX-2 inhibitors are mainly involved in antipyretic and anti-inflammatory properties. So the COX-1 enzymes are present in platelets, kidney, and stomach. Some of the most common used ones are the ketorolac and ibuprofen. Ketorolac dosage is given here, usually given 2 hours prior to surgery, 15 to 30 mg, and ibuprofen could be 800 mg 1 to 2 hours prior to surgery. Then we have COX-2 inhibitors, which have less platelet and gastric side effects as compared to COX-1 inhibitors. Examples are celecoxib, rofecoxib, and etoricoxib. Then we have paracetamol. The IV formulation of paracetamol. The paracetamol basically has a COX-3, acts on COX-3 isoenzyme, and it can inhibit central prostaglandin synthesis. IV paracetamol is quite favored, and where the bioavailability is 100% and pain relief happens less than 30 minutes. It is the absolute contraindication is mainly in liver failure patients. The dosing guide is given here, where for an adult more than 50 kg, you can give up to 1 gram every 6 hours to a maximum of 4 grams per day. This study shows the benefits of IV paracetamol over oral paracetamol, wherein it shows that opioid usage was less, as well as there was better post-operative pain control. Opioids, they basically act on mu receptors in the CNS and PNS. They are used for high degree of analgesia, and they activate the descending pathway. Some of the strong opioids used are morphine, fentanyl, and some of the new weak opioids used are tramadol and Tidal. Tramadol is synthetic opioid. It has only 1/10 the potency of morphine, and dosage is around 100 mg every 8 hours IV. Tidal is again 2 to 3 times less potent than morphine. It has dual central action. It's available in tablets of various formulation. Maximum dose is 600 mg per day. So this table shows various opioids, the onset of action, and the peak effect, and the duration of clinical effects. And there is also the IV and PCA bolus and rates that can be used. If you see, fentanyl and sufentanil are 100 to 1,000 times potent compared to morphine. So steroids are mainly, their function is anti-inflammatory, reducing the flood of inflammatory mediators. There are several steroids used in practice: dexamethasone, methylprednisolone, deflazacort, and they basically have anti-inflammatory effect and reduce the onset and increase the duration. When added to local anesthetics in nerve blocks and epidural analgesia, they can increase the duration of analgesia. This was a study which was formulated. I mean, this study reveals that dexamethasone has some kind of analgesic effects. Even though there was increase in blood glucose levels, there was no apparent side effects. So NMDA receptors like magnesium
Dr.
and
Annie, I'm
ketamine.
really sorry, but you have to stop your presentation. You have exceeded
Okay.
twice the time. You have to understand everyone has to stick to the time. Okay?
Okay, ma'am.
Thank you so much. Just go on the last slide of your presentation, take home message if you have any. I'm really sorry, but it's thrice the time you have been allotted.
Okay, ma'am.
It is important to stick to the time because
Yeah, that's what, because everybody has to be, there are three important topics. You have to very well stick to the time. And this is not only for her, for everybody else.
Okay, ma'am. I'll just finish it off with the last slide. So we have seen a lot of pain multimodal strategies. So we have to weigh the advantages against the disadvantages. So we have the reduction in pain intensity score, opioid sparing effect, and reduction in opioid use, which are advantages of the MMA. But we also should know a knowledge of multiple drugs and adverse effect profile. And therefore, from this, we can learn that there is lower doses which can be used in MMA, early mobilization and rapid recovery, and reduced side effects. So aggressive preemptive MMA, including regional anesthesia, produces optimal analgesia and also prevents the occurrence of chronic pain after surgery. Thank you.
Thank you so much, Dr. Annie. Can we move to the next presentation, please?
Next we have, yeah. Functional anatomy of nerve and plexus of nerve fibers and nerve conduction by Dr. Thomas Joseph from St. John's Medical College Hospital, Bengaluru. Over to you, Dr. Thomas.
Thank you, ma'am. Good evening, respected teachers and friends. Myself, Dr. Thomas Joseph, doing Aora Fellowship from St. John's Medical College under the chief mentorship of Dr. Manjula Devi. My moderator for the session is Dr. Upinder ma'am from Dayanand Medical College and Hospital, Ludhiana. So first of all, I would like to utilize this opportunity. I would like to express my gratitude to all the Aora faculty members for providing me an opportunity to present in a national stage. So moving on to my topic for the day is functional anatomy of nerve and plexus, types of nerve fibers and nerve conduction. So moving on to first topic, functional anatomy of nerve and plexus. So we all know that nervous system is basically comprising of neurons as well as the supporting cells, that is the glial cell. So about the neuron, that is the structural as well as the functional unit of nervous system. It basically consists of three parts, that is a cell body, dendrites and axon. So cell body contains large euchromatic nucleus with large nucleolus, which controls the all the functions of the nerve, and the cytoplasm contains rough endoplasmic reticulum, ribosomes, etc. for the neurotransmitter synthesis as well as the other protein synthesis, and the Golgi apparatus for post-translational modification and packaging of proteins, and neurofilaments as well as microtubules for the structural support, and mitochondria for ATP synthesis. So the ribosomal rosettes as well as the rough endoplasmic reticulum together forms the Nissel's granules involved in neurotransmitter synthesis as well as the axonal transport. So here in this diagram we can see the cell body. This is the with the various organelles as described earlier, and this is the dendrites which receive impulses from adjacent neurons, and the impulses are transmitted to the cell body and to the axon. So this part is the axon hillock. So this is the area where it receives excitatory postsynaptic potential as well as the inhibitory postsynaptic potential, IPSPs and EPSPs, where the summation of impulses occurs. So if at all the stimulus exceeds the threshold, then it will be transmitted to the initial segment, which is called as a trigger zone, where the initiation of action potential occurs. So it is the initial segment is the zone between the axon hillock and the starting of myelin. So histologically, how we can differentiate this axon hillock is the absence of Nissel's granules. And in the dendrites, we can see the absence of Golgi apparatus. Those are the two hallmarks of these parts. So the slides we have already explained. Dendrites, receptive branches arising from the cell body, deficient in Golgi apparatus. Axon is the extension from cell body. And the initial segment is the trigger zone between the cell body and the start of myelin. And the synapses are the specialized junctions between neurons or between the neurons and cells, which enables the transmission of nerve impulses. So that is regarding the neuron. Schwann cell is one glial cell, which is the supporting cell in the peripheral nervous system, which is involved in myelination of the nervous system in peripheral nervous system. Whereas in central nervous system, it is done by the oligodendrocytes. So myelin sheath is nothing other than the modified plasma lemma of Schwann cell. So here in this diagram, you can see the neuron with cell body and the axon. This is the node of Ranvier where the myelin sheath is deficient, and the area between two adjacent nodes of Ranvier is called as the internode. So the magnified picture we can see of the internode, where we can see the Schwann cell with its nucleus and cytoplasm, and it's forming the myelin sheath. How it is forming is by repeated wrapping of Schwann cell around the axon. So with each wrapping, the cytoplasm of the previous wrapping will get compressed, and this is how myelin sheath gets formed. So here we can see some more structures called paranode, JXP, etc. Paranode is the area just proximal to the node of Ranvier, where the myelin sheath joins the axon. And juxtaparanode is the region just proximal to the paranode, where there is high concentration of potassium channels, helping in repolarization of the nerve. And SPJ stands for Schmidt-Landerman junction. So which is basically some cytoplasmic channels providing support for the nutrient exchange between the myelin sheath. And you can see the microvilli of Schwann cell, which helps in attachment of the myelin sheath to the axon. So basically, we have two types of nerve fibers: if it myelinated and unmyelinated. So in myelinated fibers, each myelin sheath is produced by Schwann cell by repeated wrapping, and the cytoplasm is compressed, as we have already mentioned. So myelin is composed mainly of 70 to 80% of lipids and 15 to 30% protein. Why it is important to us is that during our blockade, myelinated fibers are blocked faster because our local anesthesia is anesthetic drugs are lipophilic. So as the amount of lipid increases, it will block the myelinated fibers faster. And the myelin proteins include protein 0, peripheral myelin protein 22. Basically, these are involved in the structural integrity as well as holding the myelin sheath tight. So the mutation of these two proteins can be seen in Charcot-Marie tooth disease. And myelin basic protein is another protein. The clinical implication is antibodies to this protein can be seen in demyelinating disorders. Node of Ranvier, internode, everything we have explained in the diagram. So how transmission occurs in myelinated nerve fibers is by saltatory conduction. Saltatory conduction is a type of conduction in which action potential jump from one node to another. So nodes are basically containing very high concentration of voltage-gated sodium channels. So from in one node, the depolarization occurs, and the myelin acts as a high resistance to the propagation. So it cannot pass through the substance of myelin sheath, whereas it goes out and jumps to the next node, depolarizing the next node. So the advantages are faster conduction velocity as well as energy efficient transmission. So here we can see the myelinated nerve fibers as well as unmyelinated. In unmyelinated, we can see one Schwann cell is covering multiple neurons, whereas in myelinated, one Schwann cell is covering multiple times a single neuron, single axon. So unmyelinated, we have told ensheathed by Schwann cells, but lack myelin. Multiple axons it's covering. So its characteristics involve, it is predominant in cutaneous nerves, and the ratio of unmyelinated is to myelinated fibers in one neuron is 3.7:1. So the conduction velocity here is proportional to the square root of fiber diameter, whereas in the other, it's directly proportional to the fiber diameter. So this is in a nutshell, the differences between myelinated and unmyelinated.
You can go
So that
forward.
is okay, ma'am. So that is regarding the neuron. Now talking about the supporting cells, we have four main supporting cells in the CNS. The first is the astrocyte. You can see that is the largest of the supporting cell. It is star-shaped, and its function is formation of blood-brain barrier. And the other function is it forms the scar tissue after injury, and it also regulates ion concentration, nutrient concentration, etc. And the second supporting cell is the oligodendrocyte, which is the most common type of supporting cell. And its function includes the myelination in central nervous system, a counterpart of Schwann cell. It has fewer processes compared to the astrocytes. So the third one is the microglia. Microglia, its main function is phagocytic. So it has fewer processes compared to astrocytes and the oligodendrocytes, and it protects the CNS from by process of phagocytosis. And the last cell is ependymal cells. These are epithelial lining, which is cuboidal to columnar in shape, and its function is formation and circulation of CSF and absorption of CSF. And the next thing is regarding the supporting cells in the peripheral nervous system. We have two cells, that is the satellite cells and the Schwann cells. Satellite cells, we can see, are the flat cells surrounding the nerve cell bodies in the ganglia. So its function is to regulate oxygen and carbon dioxide and other nutrient levels. About Schwann cells, we have explained in the previous slides. That is regarding the glial cells. Now the next slide is about connective tissue coverings of peripheral nerves. So we can see this is a horizontal cut section of spinal cord with the dorsal root ganglion and the spinal nerve. So here the entire covering of the full spinal nerve is called epineurium. Whereas in the cut section we can see multiple fascicles. Each fascicle has its own covering, that is called the perineurium. And the innermost covering, that is the covering of each individual neuron, is called endoneurium, about which we will talk in detail. So epineurium is the outermost connective tissue composed of loose areolar connective tissue. It binds multiple fascicles into a single nerve trunk, and it represents 30 to 75%. So here we have, it is further divided into two, epifascicular as well as interfascicular epineurium. So this is important to us in giving the local anesthetic. So our area of target is epifascicular epineurium. So if we are giving interfascicular, the risk of nerve injury is more. but the onset of action will be higher in interfascicular. So next is the perineurium. It is regarding surrounding each nerve fascicle located between epineurium and endoneurium. It consists of flattened polygonal cells. So a typical nerve trunk contains 15 to 20 perineurial cell layers, and it acts as a diffusion barrier. For it maintains the chemical environment of nerve fibers. So higher the perineurial tissue, slower is the onset of action, and it maintains the osmotic balance and fluid pressure. Endoneurium is the innermost connective tissue layer which surrounds individual nerve fibers. Consists of loose areolar connective tissue. So this is an article showing connective tissue associated with peripheral nerves published in Regional Anesthesia and Pain Medicine. Here there is a cut section of sciatic nerve at the popliteal level. They are showing the tibial component as well as common peroneal with its common paraneurial sheath. So here you can see both tibial as well as common peroneal nerve with its epineurium, and there is a common paraneurial sheath which is described later in later studies. So this is another article by Dr. Manoj Karmakar defining the various facial compartments. Here also we can see the common peroneal as well as tibial nerve with its individual epineurium, and the common paraneurial sheath is nothing other than the modified epimysium of the gluteal muscles. And this is another article from Regional Anesthesia and Pain Medicine regarding extrafacial and subfacial injections. So here in extrafacial injection, you can see the cords are not well separated. Whereas in subfacial injection, you can see the cords are well separated. So they have concluded that the onset as well as the duration of action and density of block is much higher in the subfacial injections. And lastly, regarding Obersteiner-Riedlich zone, that is the junction between central nervous system and peripheral nervous system. We have told that in central nervous system, myelination is by oligodendrocytes, and in peripheral, it is by Schwann cells. So the junction of at the subarachnoid angle where CNS continues as the PNS is called as Obersteiner-Riedlich zone. So that is regarding the functional anatomy of nerve and plexus. So next is regarding plexus of nerves. Next is regarding the plexus, which is nothing other than interlacing nerve fibers from different spinal roots. So here you can see the arrangements of different nerve fibers in plexus at different levels in brachial plexus. So this is the at interscalene level, we can see C5, C6 root, C7 root, and C8, T1 root. So here it is more hypoechoic since the connective tissue element is less in the proximal part. As we go down, we can see the connective tissue element is more in supraclavicular as well as infraclavicular as well as the axillary. When we go from the proximal to the distal level, we can see the nerves appear more hyperechoic. That is, the connective tissue element is becoming more compared to the connective tissue ratio is more compared to the nervous tissue. In the lower limb, we can see the at the popliteal as well as the subgluteal level, the sciatic nerve, how it appears. Here we can't make out the fascicles much better, but here we can see it much better. The connective tissue element is more. So that is regarding the functional anatomy of nerve and plexus. Moving on to my second topic, that is a type of nerve fibers. There are basically two types of classification, that is the Erlanger and Gasser classification as well as the Lloyd and Hunt classification or the sensory classification. So in Erlanger-Gasser classification, the nerves are divided into A, B, and C. So the A and B fibers are myelinated, whereas C fibers are unmyelinated. So the diameter and conduction velocity, it gradually decreases from A alpha to A beta to A delta to C fibers. And the functions we have mentioned here. Regarding the Lloyd and Hunt classification, it is the sensory classification regarding sensory nerve fibers. It's classified into type 1A, 1B, 2, 3, and 4. It is 1A and 1B is corresponding to A alpha fibers of Erlanger-Gasser, whereas type 2 is corresponding to A beta fibers, whereas 3 is corresponding to A delta, while type 4 fibers are corresponding to dorsal root C fibers. So this slide we have already mentioned. Nerve fiber diameter and myelination determine the impulse conduction velocity. Larger and myelinated fibers conduct faster. So here comes one important concept called differential nerve blockade. This is refers to the unequal blockade of different nerve fibers during regional anesthesia. Like when pain fibers are completely blocked and still touch and motor fibers are intact. This is through four mechanisms mainly. That is the temporal differences in drug distribution. We have mainly two types of fibers. That is the core fibers as well as the mantle fibers. Core fibers are in the center, which is blocked later. The mantle fibers at the periphery are blocked initially. So the mantle fibers are supplying the proximal part, whereas the core fibers are supplying the distal part. So that's why when we are blocking the brachial plexus, we can see the shoulder is getting blocked first rather than the fingers. So the second mechanism is fiber diameter and conduction properties. So if it is myelinated, it will get blocked faster, and as the size of the diameter of the neuron increases, it is blocked last only. The order of blockade is like B greater than C greater than A alpha, A beta, A delta, A gamma, A beta, and A alpha. A alpha is the largest one. And the last one is third mechanism is anatomical features of nerve fibers, in which we have already mentioned three coverings: endoneurium, perineurium, as well as the epineurium. So here the most important layer is perineurium, which acts as the diffusion barrier. So there is a concept called perineurial index, which is nothing other than the ratio of diameter of the thickness of perineurium to the thickness of diameter of fascicle. So higher the perineurial index, slower is the block onset. And the fourth mechanism is variation in ion channels. So higher the amount of ion channels, voltage gated sodium channels, higher is the faster is the block onset. And my last topic for today is nerve conduction. So nerve conduction occurs through sequential depolarization and repolarization of the nerve membrane. So all cells have resting membrane potential, which is a potential which occurs between the cell membrane during the resting stage. This is maintained by a pump called sodium-potassium ATPase pump, which actively pumps 3 sodium in and 2 potassium out. So in nervous tissue, it maintains an RMP of -60 to -70 millivolt. So how the action potential initiation and propagation occurs is when the stimulus, that is the EPSP and IPSP, reaches the axon hillock, when it exceeds the threshold, the voltage gated sodium channels open up, and there will be a rapid sodium influx. So the membrane potential becomes less negative. So here in this diagram, we can see here the stimulus comes. Once it crosses the threshold, rapid influx of sodium ions occurs, and once it reaches the peak, then slowly the potassium channels open up, leading to potassium efflux, causing the repolarization phase. And these potassium channels are slow to close, so there will be more efflux of potassium than the resting membrane potential. That is called the after repolarization phase. So here we are also able to see this phase is called the latent phase. So this is the refractory phase. So this is the absolute refractory period where a supramaximal threshold stimulus cannot create an action potential, and this is the relative refractory period where a supramaximal stimulus can produce an action potential. So depolarization phase, we have mentioned rapid influx. So it is self-propagating and all or none response. All or none means if it crosses the threshold, it produces an action potential. If it doesn't cross, it doesn't create action potential. And the repolarization phase is characterized by inactivation of sodium channels as well as opening of voltage-gated potassium channels. So the propagation occurs via the local currents from active region depolarize adjacent segment, and it reaches the threshold and generate new action potential. So this is how it produces sequential propagation. So to completely block impulse propagation, we need to block at least 3 to 5 consecutive nodes. So here comes two important concepts called margin of safety and decremental conduction. Margin of safety is that extra amount of current available for depolarization. So the current entering the adjacent region is 5 to 10 times greater than the threshold. So this ensures reliable impulse propagation. So because of this large margin of safety, we need to at least block 80% of sodium channels for cutting the propagation. So the next concept is decremental conduction. It is opposite to all or none phenomenon. That is when the local anesthetic is injected, so it gradually blocks the sodium channels. So when the excitability is reduced, action potential amplitude slowly decreases and the conduction velocity stops, further resulting in stoppage of impulse propagation. So this is the nutshell of types of conduction. Where we have two types of conduction: continuous as well as saltatory. Continuous conduction occurs in unmyelinated fibers where the depolarization spreads along the entire axon membrane, and it has a slow conduction velocity 0.5 to 2 meter per second. Whereas in saltatory conduction, it occurs in the myelinated nerve fibers where the impulse jumps from between the nodes of Ranvier, and the conduction velocity is much faster, 70 to 120 meter per second. So these are my references. Thank you.
Thank you, Dr. Thomas Joseph. Next, we have Dr. Sushmita from Aster CMI Hospital, Bengaluru, who's going to present about pathophysiology of pain, nociceptive versus neuropathic pain. Dr. Sushmita, are you there?
Yes. Yes, ma'am. Can you see me, ma'am?
We
Can you
can't
see
see
the
your
presentation?
slide. No, not yet.
Can you see now, ma'am?
Yeah.
Can you see now, ma'am?
Yes, you can go ahead, Dr. Sushmita.
Good evening to everyone present over here. I'm Dr. Sushmita. I'm an Aora fellow from Aster CMI Hospital and under the mentorship of Dr. Arun, Dr. Gaurang and Dr. Renita. So today my topic for today is pathophysiology of pain, nociceptive versus neuropathic. So today I'll be briefly going through contents, that is a definition, classification of pain, types of pain, nociceptive versus neuropathic, peripheral and central sensitization, modulation of pain, and summary concluding the difference between the two pains. The International Association's study for pain definition of pain states that it's an unpleasant sensory emotional experience associated with or resembling that associated with actual or potential tissue damage. It includes both sensory discriminative as well as motivational affective components. No, I think classification of the pain has already been covered, but I will briefly discuss. It is divided into acute pain and chronic pain based on the duration. Acute pain is provoked by tissue damage and ongoing noxious process, example, a surgical trauma, whereas a chronic pain is something that persists or recurs longer than 3 months, and it persists beyond the period of the time that is normally expected. Classification based on the etiology is physiological pain and pathological pain. Physiological pain occurs in absence of an actual tissue or nerve damage, example muscle cramp or an abdominal colic, whereas pathological pain occurs in presence of tissue or nerve damage, and it is accompanied by sensitization, which results in the clinical phenomena of hyperalgesia and allodynia. Hyperalgesia is increased pain at a suprathreshold stimulus, whereas allodynia is a misperception of a pain to a stimulus that normally does not produce a pain. Classification of the pain based on location, somatic pain and visceral pain. Somatic pain from joints, muscles and skin and usually is very well localized, whereas a visceral pain is often poorly localized because it receives diffuse inputs from multiple spinal segments and is usually associated with referred pain. So what is a pain system? Is a neural circuit, has already been explained. When a noxious stimulus is happening, it is going to get nociception usually encompasses 4 stages. That's the transduction, transmission, modulation and perception. So transmission, when a mechanical or a chemical or a thermal injury is formed, it is going to get converted into electrical impulses, that is the transduction. When it is going to get generated into an action potential and transmitted, that forms the transmission. And then there is a modulation, which can either excitatory, which can help in progression of the pain, or inhibitory in nature, that is the modulation of the pain. And finally is the perception at the cortical center, and perception is basically the perception of the pain after all this process. Now, types of pain is a nociceptive, neuropathic, and inflammatory pain. Coming to the nociception, what are the nociceptors? Are basically primary afferent neurons which are involved in the detection as well as the transmission of the pain are called as nociceptors, and they are going to perform 2 functions. The first one is detection and encoding of the noxious stimuli and the transmission of this into an action potential and to the central nervous system. Another function of this nociceptors are synthesize and release of neuropeptides like the substance P and the CGRP. Neuropathic pain results from direct damage to the somatosensory nervous system, and it includes positive symptoms as well as negative symptoms. Positive symptoms includes allodynia, hyperalgesia, and paresthesia, whereas negative symptoms includes hypoalgesia and hyposthesia. Inflammatory pain, whenever a peripheral injury occurs, there's tissue damage and release of various inflammatory cells and mediators, which will cause inflammatory pain. Now, coming to the peripheral sensitization, So how does this peripheral sensitization usually occurs? The nociceptor cell bodies are usually rooted in the dorsal root ganglion, where they are going to usually synapse with the second order neuron, that is the dorsal horn neuron, either with the dorsal horn neuron or the interneurons of the dorsal root ganglion. And these nociceptors are going to transduce, that is convert a chemical or this thing into an electrical impulses, that is the afferent action potentials, with the help of an ion channel. And the main ion channels responsible for peripheral sensitizations are the TRP channels and the voltage gated ion calcium channels. Along with this, the damaged tissue as well as inflammatory mediators are also going to sensitize these ion channels, and they're going to help in contributing to development of an action potential and the propagation of the pain by the modulation of all these ion entry. Coming to the primary afferent neurons, that is the A delta and C fibers, which are going mostly are the pain fibers. They're going to relay in the second order neurons. A delta fibers are usually myelinated and they have a faster conduction velocity, therefore, and they are going to receive inputs with regard to the mechanosensitive or the mechanothermal, where compared to C fibers are unmyelinated, have low conduction velocity, and they are going to they're polymodal, which means that they receive multiple inputs from it, could be chemical, mechanical, or thermal. The A delta fibers usually produce a stabbing, burning, pricking type of pain, whereas C fibers are usually going to produce a dull and aching pain. So this is the comparative between the three type of fibers. Now, coming to the mechanism of peripheral pain sensitization. So whenever an injury occurs at the peripheral region, so whenever an injury occurs at the skin, one is at the level, another one is going to be, root is going to be transferred to the dorsal root ganglion at the spinal cord. So what happens at the peripheral injury? There are the inflammatory cells, that is the neutrophil and macrophages, which are going to release all the various inflammatory mediators like the bradykinin, prostaglandin, nerve growth factors, interleukins, which are going to go and bind with the specific receptors. Like prostaglandin receptors or acid ion sensing channel receptors, and they're going to initiate this cascade of protein kinase A, protein kinase E, and they're going to activate this TRPV1 gene, which causes neuronal hyperexcitability and pain hypersensitivity, which are going to contribute to the pain hypersensitivity. Now, peripheral pain sensitization, the one of the root that is carried is the dorsal root ganglion. At the dorsal root ganglion also the same thing occurs, where inflammatory mediators are going to bind to the respective channels, and they're going to activate this mTOR gene, which is going to further activate this release substance P, nerve growth factors, and they're going to help in conduction or the pain hypersensitivity. From here, one of the root is going to go from here, the dorsal root ganglion, it is going to go into the central nervous system. Now, coming to the central sensitization, you know that the gray matter of the spinal cord is divided into 10 lamines into 10 lamines by Rex. So the nociceptors are usually going to relay in the 1, 2, and 5 lamines of the dorsal root ganglion, and the majority of the C fibers are going to terminate in the lamina 2, that is the substantia gelatinosa. So central sensitization includes two pathways. The first one is the neural inhibitory as well as the neural activating pathways. So neural activating pathways, in that comes the glutamate. Glutamate is the excitatory neurotransmitters that is mainly responsible for the central sensitization by binding to the AMPA receptors, NMDA receptors, and glutamate receptors. Activation of the NMDA receptors is essential for initiating and maintaining the central sensitization. So this is going to be until the NMDA receptors combining to the glutamate binding to all these receptors is going to be the ascending or the activating pathway, where there is also a descending pathway, which is going to be the inhibitory pathway, that is the anterior, which comprises of anterior cingulate gyrus, periaqueductal gyrus, RVM. All these play a large part in the descending pathway, which are going to be inhibitory. So any disruption to this inhibitory pathway can also upregulate these the activating pathway and can initiate cause the brain hypersensitivity. So this is the mechanism. So whenever there is a central sensitization, there's release of all these neurotransmitters like substance P, ATPase, which are going to bind to the NMDA, AMPA receptors, and they're going to cause the neuronal hyperexcitability. Another one in the central sensitization is going to be the activated astrocytes and microglial cells, which are going to further contribute to this central sensitization. Now, coming to the ascending tracks, the sensory discriminative and the affective pathways. The sensory discriminative pathways enable a nociceptive stimulus to be localized and its different qualities such as character and severity be to distinguish, whereas an affective pathway are going to tell us about the multidimensional nature of the pain response, which is the affective, emotional quotient of the pain. The sensory discriminative pathways are going to travel through the spinothalamic tract and the trigeminothalamic tract. That is the sensory discriminative that travels from the face and the head is through the trigeminothalamic tract. And these through the spinothalamic tract are going to relay in the VPN of the thalamus, and from where the third order neurons are going to project to the somatosensory cortex. Next one is going to be the affective pathways are going to travel through the spino-reticular tract, and they're going to radiate to the PAG, the parabrachial nuclei, and the reticular formation. Another pathway of the spino-reticular, they're going to go and relay signals to the visceral nucleus of nucleus tractus solitarius, limbic system, and descending inhibitory system. And therefore, these are going to take care of the emotional and the aspective of the pain. Coming to the cortical, the higher centers, how are they going to control the different components of the pain? The primary sensory cortex and secondary sensory cortex are the ones which are going to be involved in perceiving the location and duration of the pain, whereas the insular cortex and the anterior cingulate gyrus are the ones which are important in the emotional, affective, and the motivational aspects of the pain. Coming to the pain suppression system in the brain and spinal cord, the endogenous pain suppression system present in our body is the brain opiate system that is consists of endorphins and enkephalins, which are going to go and bind to various receptors like mu receptor, delta, kappa receptors, and they're going to provide profound analgesia. So how this brain and opioid systems are going to produce profound analgesia by basically hyperpolarizing the neuron and thereby reducing the pain, that is disrupting the action potentials and therefore reducing the pain hypersensitivity and pain propagation. And brain's opioid systems actually produces a sense of euphoria and of well-being. This is basically how a morphine mimics a endorphins function. So this is the receptors. Now coming to the modulation of the pain. So the modulation of the pain, two main pathways, that is the gate control theory, which was put forth by the Melzack and the Wall in 1965. So how this occurs is basically the usual pathway is going to be the nociceptors, the pain pathway A delta and C fibers are going to go and they're going to synapse either with the dorsal horn neuron at the synapse level or with the interneurons, and they're going to go through the tract to the third order neuron and they're going to go and relay in the cortex. That is the usual pathway. But the synapse level at the dorsal horn can be gated or it can be controlled. How? By the A beta fibers, which can go and they can act at the synapse level. That is by activating the inhibitory interneurons. The interneurons that is present between the primary and the dorsal horn cells can be inhibitory or excitatory. So what these A beta fibers, they're going to go and activate this inhibitory interneurons and they're going to gate or close the gate that is usually open. The usual primary part, it is going to go and close. Another pathway that can actually close this gate again is going to be the descending modulatory systems at the primary synapse, either directly or via the opioid secreting interneurons. So this is the gate control theory, and this is basically how, based on this mechanism, this is how various methods are going to be used, like TENS, trans-electrical nerve stimulations and spinal cord nerve stimulations are all going to act based on this. Now coming to a descending modulatory system, the periaqueductal gyrus, the descending modulatory system basically consists of three main things: the periaqueductal gyrus, rostral ventromedial medulla, as well as the spinal cord. So this PAG is usually a gray matter that is present around the aqueduct of Sylvius, and rostral ventral medius is going to be present in the floor of the medulla and the spinal cord. So this PAG is injecting morphine around the PAG actually produces profound analgesia. So what are the pathways that activate this PAG is the endogenous opioid morphine. Another one is the cortical centers, like which include the hypothalamus, thalamus, limbic system, and cortex. And collateral spinothalamic tract can activate this PAG, and they can further activate this rostral ventromedial nuclei, which can act to the spinal cord through the three pathways. Either it can go and inhibit the dorsal horn neurons directly at the spinal cord, or it can inhibit the excitatory interneurons at the dorsal horn, or it can excite and inhibitory interneurons at the dorsal horn. And whole in all, it can cause it. This system causes inhibitory effect on the pain transmission. This is a descending modulatory system. Now, coming to the neuromodulators, there are excitatory modulators like cholecystolacin, prostaglandins, and inhibitory neuromodulators like opioids, cannabinoids, and acetylcholine, which are going to, which can be excitatory or inhibitory, and which are going to help in the excitation of the pain or inhibition of a pain. So overall, I'm going to conclude what is the difference between a nociceptive and versus a neuropathic pain. Nociceptive pain is usually caused by an actual tissue damage or an inflammation, and it originates by activation of a nociceptors. And the mechanism is stimulation of pain receptors by a harmful stimuli. And the usual type of pain that is produced by nociceptive pain is an aching pain, throbbing or sharp pain, and it's usually proportional to the injury that occurs. The common examples of a nociceptive pain is an acute pain like an incisional pain or arthritis or burns or a surgical trauma or a RTA, anything like that. And it involves both somatic and the visceral pain pathways, and is generally very well localized. Usually responds well to NSAIDs and simple analgesics. Whereas coming to the neuropathic pain is caused by damage or dysfunction of the nervous system, and it originates from injury to the nerves or abnormal nerve signaling. And mechanism is abnormal processing of the pain signals in the nerves, and usually is described as burning, tingling, or electric shock-like pain. And pain may occur without any obvious injury. And it is common in nerve conditions like diabetic neuropathy, post-herpetic neuralgia, or trigeminal neuralgia, CPSP syndromes. And even in multiple these are all the peripheral. When it comes to central, it could be these stroke, multiple sclerosis, Parkinson's disease, which can produce neuropathic pain. And it involves peripheral or central nervous system damage in the examples, and it is often poorly localized and radiating. So neuropathic pain does not require, it requires multifaceted, it is multifaceted, and it requires multiple aspects to be treated there. It often requires antidepressants, anticonvulsants, and nerve pain medications. Thank you.
Thank you to all the fellows for beautifully illustrated presentations and also for trying to simplify these complex concepts so effectively. I now request our moderators to please share their perspectives and lead the discussion.
Yeah, good evening, everyone. I think Annie had a very vast presentation. I know it's a lot of theoretical concepts here. And I suggest all the fellows to go through this and repeatedly revise to understand the mechanism of pain. So as far as the regional anesthesia is concerned, it's a very good preemptive effect. So I think it's a vast coverage, and it requires repeated revision, as I always say about the pain. So I think I can leave the discussion open to the other moderators as well.
Yeah, so good evening, everyone. Thank you all the three AORA fellows for presenting your topics. Just a suggestion, brief suggestion, please, slightly elaborate in the sense that when because we all have limited attention, we should presentations, and only the salient points which you actually retain should be there on your PowerPoint presentations, should be there. So anyway, congratulations to all three of you, and I would open the, it's already opened actually. Any fellows who like to ask any questions?
I just have a suggestion. When there's a topic like this which are interrelated, I think the fellows also should discuss what is covered in the other one, so that there'll be a wonderful time management, because there were so many
Yes, that is very important.
Yes, so that it'll be precise and take home. If other colleague is hearing that, so that they can quickly grasp whatever is required. Whatever concepts are important and everything. So it becomes, yeah. Anyway, it's a great effort by all of you. So
Yes, definitely. Great effort. When making slides is not an easy task. So, I think all the moderators have given in their best effort in taking home the salient clinical points which are to be applied when you are a regional anesthesiologist as such per se. So again, I'm this all the three topics are open for discussion to all the fellows. If you have any questions or any queries, they can be put forward. And let me tell you, these three topics which are there, out of these three topics, you will definitely, when you sit for your exit exam in the AORA, definitely at least two questions are going to come from these, particularly these three topics, because these are very basic topics and all the fellows should know the basic anatomy of a nerve, the basic action potential which is generated, what are the pain pathways, and how do you actually, what are the pain pathways, what is neuropathic pain, and all the kind of receptors which are there, it should be known.
Ma'am, can we ask all fellows to prepare a small note on this and share on the group?
Yes, definitely, Dr. Hetu. That's a very good idea. They can definitely, especially the structure of the nerve, because many a times it is asked in the practical exam also, and then the fellow actually, few of us actually, they kind of stumble over there regarding the layers, which is the epineurium, which is the endoneurium, perineurium. So
there are a few questions. Dr. Sushmita, is there any tool to diagnose neuropathic pain? How will you diagnose neuropathic pain? Is there any way, any questionnaire, anything, any tool? Dr. Sushmita, am I audible?
you're audible.
Recording in progress.
Hello, sir.
Yes, Sushmita, please.
Sir, can you repeat the question, sir? I could not hear.
Is there any tool to detect neuropathic pain? How will you differentiate neuropathic pain from the somatic pain? Is there any particular tool or any questionnaire which will differentiate neuropathic pain from the nociceptive pain?
Sir, the PNS, peripheral nervous, peripheral nerve stimulator, sir.
No, not talking about it. There are certain questionnaires, there are certain tools to diagnose neuropathic pains, such as pain detect and neuropathic pain questionnaires. There are several tools to diagnose neuropathic pain, which differentiate neuropathic pain from the somatic pain when you make a diagnosis of the neuropathic pain.
Mm-hmm. That is
And Dr. Thomas, one question for you. To get an appropriate nerve block, how many nodes of Ranvier should be blocked?
The 3 to 5 nodes of Ranvier should be blocked.
Yes, at least 3. Otherwise, there will be jumping of sodium. Yeah. And there was a very beautiful paper which was published in January 2026 by MacLeod. Have you read that article? Where
Please key into DN4.
Insight of the macroanatomy of the nerves.
Okay,
Where
I'll go through.
This is where one additional layer is mentioned around the perineurium, which was the circumfascicular fibrous layer.
That is the adipose tissue layer, sir.
No, that is not the adipose tissue. That is the fibrous layer around the perineurium.
Okay, sir.
and the word term like paraneurium is changed to the circumneurium
Okay,
in
sir.
that article, and it is very nice article which show the what is the mechanism of nerve injury and how the risk of nerve injury can be minimized uh, because of this fascicular fibrous layer, the chances of nerve penetration is very less.
Okay, sir.
Shishir, actually, I shared a video on same article on the group.
I know, sir. I know, sir. I know, sir. You have shared. You have made a lot of effort for this, but actually, it should be included in the slides of the
Yes,
Thomas
yes,
because this is.
Okay,
I
sir.
was
I was
waiting for it,
expecting.
but it was
I
not
was
covered.
expecting.
Yeah,
I
I was
sir.
expecting that. Yeah, same here.
Sir, the answer is pain detect questionnaire, sir.
Yes.
Yes,
Pain
sir.
detect is most common is the pain detect questionnaire.
Yes, sir.
So better idea for the next all the moderator and the presenter, they should be in a same WhatsApp group so that they can share slides to each other. They can suggest to each other. That will be a better idea rather sending a slide 4 hour, 5 hours prior to your moderator. I think that will be a better idea so that we can share our insights in your presentations.
Yeah, we have allotted topics for entire year, so you can prepare the slides
So-
earlier and discuss with your mentor as well as to moderator, and then present during this class. Actually, we have to include all the fellows for some presentation, so we have included multiple topics and given 20 minutes for each topic so that everybody gets a chance to present against national faculties. So request to all fellows to stick to time limit. Otherwise, it will be difficult to, finish the class within given time period.
I really liked your idea, Dr. Shishir sir. I will create a group which I will share with all of you every month, whoever is the moderator and the fellows, because we all can go through the slides and we will restrict it. And every month, the team will change in that group, but constantly me and Hetal sir will be there. So I really liked your idea. Thank you so
Thank you.
much. I'll
Thank
do it
you.
next time, sir.
If there is no question, we can conclude the session.
Thank you, Atul sir.
I will
Thank
request the
you.
fellows to stay online. The faculty, thank you so much for joining. I will just have a small discussion with the fellows.
And request to all